bowel disease is a chronic inflammation involving GYT due to inappropriate mucosal activation. We have Crohn's disease and ulcerative colitis under this. The Etiopathophysiology, the risk factors we have, the age we have bimodal peak, that is one peak in between 50 to 30 years, second peak between 70 to 90 years. The genetic factors we saw is more pronounced in Crohn's disease. Those are NOT2 mutations and syndrome, Turner syndrome, Wiskott-Aldrich syndrome, and glycogen storage type D1. The environmental risk factors like altered microbiota in hygiene hypothesis, where due to consumption of well refrigerated food which is not contaminated, the frequency of enteric infections are reduced, which with impaired training of our immune cells, which leads to increased regulatory response in the mucosa, leading on to inflammatory damage. The smoking we have in smokers increased risk of Crohn's disease. The non-smokers have increased risk of ulcerative colitis. The psychological factors, psychosocial factors are also been seen to increase the symptoms of this disease. The pathophysiology, we saw there is mutation of NOT2 gene, which leads to impaired mucosal immunity. That is impaired innate immunity, causing reduced clearance of bacteria, impaired secretion of defenses by Paneth cells, and impaired autophagy, leading on to overactive adaptive immunity, overactive B cells and T cells. In Crohn's disease, we see more type 1 helper cells activating. In ulcerative colitis, we see type 2 helper cells being activated more. This leads on to inflammatory damage, overactive adaptive immunity. Then we saw pathology, the ulcerative colitis gross. Here the lesions are superficial, continuous, asymmetrical, mostly involving rectum and rectosigmoid region. And also we can see pancolitis. Initially we see erythematous mucosa with granular appearance, followed by hemorrhagic edematous and ulcerative lesions, followed by pseudopolyps due to mucosal regeneration. In long-standing case, we can see lead pipe appearance and toxic megacolon. On microscopy, we see superficial involvement, that is in mucosa and submucosa infiltrated with T cells, B cells, plasma cells, and macrophages in the laminopropria. And also we see cryptitis with loss of crypt architecture with Paneth cell metaplasia. In Crohn's disease, we see the gross appearance. Here, the lesions are deep, transmural, and asymmetrical skip lesions. We see aphthous ulcer initially, followed by linear serpiginous ulcer, which fuse to form curve, which fuse horizontally and vertically, and then it leaves the areas called as normal area, which gives cobblestoning. And then we have creeping fat. In the perirectal region, we can see fissures, fistulas, and abscess, followed by fibrosis, which leads to thickening and strictures, leading on to the characteristic garden hose appearance.